of you who don't know me. And it is my distinct honor to serve as the chairman of the Continuing Medical Education Committee of the organization, and bringing these educational series to our members who are healthcare professionals, as well as the community at large, to get to hear the latest information on various medical or healthcare related topics. It seems that these days we've been allocating most of our energy towards various educational sessions that are pertaining to the global COVID pandemic that's turned our lives into a unique type of situation. In any event, I'd like to announce that we will have another educational session tomorrow. Please join us. We will be joined by a world-renowned expert in obesity, Dr. Carolyn Abovian, who will be joining us from New York. And the talk tomorrow is going to be on obesity and as it pertains to the coronavirus infection predisposition, and what are some of the latest information and science that we know pertaining to obesity and COVID-19. I'd like to take a moment to thank our CME committee for really working hard to bring all these sessions to you. We are, our committee, Dr. Rami Apelian, Dr. Garni Barkhudarian, who will be co-moderating this session today, Dr. Kevin Galsyan, who also is the president of the organization and who's been instrumental in having us launch these educational programs, Dr. Arsene Galfayan, Dr. Armon Kotikian, and myself, of course, Hasmit Keribarian, who is the force behind the scenes. And truly, it takes a lot of work to put these things together. And, you know, she has been working tirelessly to make these sessions come together. So, also to let you know, in the past month, as of the end of the week, as of tomorrow, the organization would have given out 20 CME credits. These credits can be claimed after participating in the sessions, either live or watching the archived webinars on our website. You can visit aamsc.org and look at the webinar tabs. You can watch the webinars, answer the questions, and claim your continuing education hours. As I said, in the past month, we have given out 20 credits thus far. So tonight we are going to, tonight we have a continuation of our physician well-being and also mental health series. We have a very, very special guest who's going to give us a lecture today, Dr. Lara Shirikjian, who's a board-certified psychiatrist in Los Angeles County. She received her undergraduate training at the University of California in Los Angeles with a BA in International Development Studies. A course of World Health at UCLA Geffen School of Medicine confirmed her initial interest in attending medical school. She completed a post-baccalaureate in pre-medical program at Scripps College through a joint science program at the Claremont McKenna College. She then attended medical school at Western University College of Osteopathic Medicine in Pomona. She went on to do an allopathic internship and residency program at Harbor UCLA. She completed her residency in psychiatry at Harbor UCLA as the chief resident. Currently, she's an adult psychiatrist with an outpatient clinic in Torrance and an inpatient practice in Long Beach. She is also the principal investigator at CNS Network, conducting research on new medications for various neurological and psychiatric indications. In the ever-evolving climate of COVID-19, Dr. Shirikjian has shifted some of her practice to telemedicine and recently launched telecarepsychiatry.com to treat patients virtually through a safe telecare portal. She's also a volunteer for the Physician Support Line, providing mental health services via telemedicine to peer physicians working on the front lines across the United States. Dr. Shirikjian, I would like to now welcome you to this platform. Dr. Shirikjian is going to talk to us about anxiety as it pertains to these days of the COVID-19 pandemic. Dr. Shirikjian, please enable your video and enable your audio, and I'd like to welcome you to take over this platform.
Okay. Hello. Thank you for that lovely introduction. Appreciate it. So we're going to just jump right in here. And let's see here. We lost the share screen feature. Sorry, one second.
So the share screen should be on the bottom part of...
Right, but I don't see the PowerPoint, and I think that's the problem.
The PowerPoint would be on your own computer.
Right, no, I see that. I see, one second. I had it, and now...
Yeah, you can relaunch it.
I will just relaunch it. I apologize.
No worries, take your time.
Okay, should be there.
And if you can just launch your presentation now.
I shared it. I will go back, share screen.
No, you had it fine. Just go back to sharing screen.
Sure.
And just launch
Sorry
the
for the
presentation.
technical. Okay. All right.
Click on that.
All right.
Okay.
Okay, thank you. All right, we're all set. So, like you said, my name is Lara Shirikjian. I am here to present anxiety in the time of a pandemic. I have no financial relationships to disclose regarding this presentation. What we're going to talk about this evening is anxiety diagnosis, what the criteria are for anxiety, how physicians, namely in this presentation, but anybody in general, may be impacted by COVID-19, and to identify treatment and management for this disorder. Let me just do this. Okay. So statistics. Anxiety is the most common mental health illness in the United States. 40 million adults in the US. This is also the most common mental health disorder in the world, but I'm going to give you the statistics for the United States in the course of this presentation. So each year, the statistic really stays around 18 to 19% of people having some form of an anxiety disorder per year. And about 31% of US adults will have some form of an anxiety disorder in their lifetime. So that's like about a third of people. As you can see, the cases are varied. You've got mild, moderate, severe. Mild, people can function and still work. And severe, you've got people who are even on Social Security benefits because their anxiety is so debilitating that they can't even work. So you've got a kind of a varied degree of illness. And what is anxiety? So there's multiple types of anxiety disorders. The most common are specific phobias like fear of spiders, fear of heights, things like that. You have separation anxiety disorder, mutism. You see that sometimes in other illnesses, but it can be a standalone diagnosis that you see as a form of anxiety. Social anxiety disorder or social phobia are common when people think, okay, I'm okay, but when I go out and I'm in a crowd, I get really anxious. Panic disorder, a lot of people talk about having panic attacks. Yet panic attacks are not specifically a diagnosis. We cannot code that. We cannot bill for that. Panic attacks are things that happen, but they are not their own diagnosis. And there is more to panic disorder than just panic attacks. But I wanted to put that caveat because some people think that they're different and that they're both disorders that are coded. We've got agoraphobia, generalized anxiety disorder, And then you've got anxiety that's induced by medications that we prescribe, or substances, illicit drugs that people are using. And then other medical conditions. You've got, for example, thyroid problems have depression as a result. Same thing goes for anxiety. There's certain medical conditions that can cause anxiety. A lot of endocrine things, cortisol hormone releasing type of disorders and whatnot. So anxiety is a symptom and a diagnosis. Everyone has anxiety. Everyone has experienced anxiety in some form at some point of their life, if not at some point of the day. And it's physiologically made for a reason. It's made for us to protect ourselves. If there's a truck merging onto the freeway as you're in the first lane, that anxiety kicks in so that your body and your brain react quickly and you go. You need that anxiety to survive as a human. But some people operate with anxiety on a daily basis all the time, and it becomes a problem. That's when it becomes a diagnosis. And when we talk about anxiety, what we're referring to most of the time in a clinical setting is generalized anxiety disorder. And what is generalized anxiety disorder? So the DSM is the criteria, it's the book, it's the Bible that we use to diagnose mental illness, so that myself in California sees a patient and we can identify symptoms just as anyone else in any other part of the world can. It kind of keeps a cohesive diagnosis for something that's kind of hard to, it's not a tangible, you can't get a lab for anxiety. So this is how we monitor it and how we diagnose. So the criteria, you have to meet each point. So point A, you have excessive anxiety and worry more days than not for at least 6 months. It can go on for 20 years. It doesn't need a break like depression does, but you need to have this diagnosis for at least 6 months. The individual finds it difficult to control the worry. So if you can control the worry, then you do not meet the criteria for generalized anxiety disorder. You may for other types of anxiety disorders, but not this one, which again is the most commonly known for when we talk about anxiety. Anxiety and worry are associated with 3 or more of the following 6 symptoms: feeling restless, keyed up, or on edge, tiring easily, concentration problems, irritability, muscle tension, or sleep disturbance. And that sleep disturbance can be anything: not having a restful sleep, difficulty falling asleep, staying asleep. It doesn't matter as long as you can identify it as being a sleep disturbance or that your patient is complaining to you in the office. And I want to point out, all the information I'm giving you is for adult, but for the criteria for children, you only need one of these to meet criteria for anxiety disorder in children for generalized anxiety disorder. You also need to rule out any other medical issues or substance abuse or any other mental health diagnosis that might be more of the reason, and anxiety is secondary. So again, with generalized anxiety disorder, this accounts for 110 million disability days per year. And that's huge. That doesn't mean we have 110 million people on, Social Security benefits for this, but people miss work because their anxiety becomes so overwhelming. And this is a big deal because it is a third of the population is experiencing some form of anxiety disorder. And as you can see by this graph, you have more or less the same in as far as prevalence with the different age ranges, and it drops off 60 and over. Why? Well, you've got people who are retired, mortgages are paid off, they've raised the kids. The daily stressors that really wear at people might be lifted at that age, or so we hope. But that would be maybe a speculative reason for that varied difference when they're over 60. So you have someone with anxiety. What's the differential diagnosis? It's not just other anxiety disorders. It's other things like depression could be a differential, obsessive compulsive disorder, post-traumatic stress disorder. A big component of that is anxiety. And again, like I alluded to a little while ago, 9.1% of people with anxiety have some sort of certain phobia. So again, fear of anything in particular. Depression and anxiety go hand in hand. Usually where there's one, there's the other. You can have anxiety and not have depression. You can have depression and not have anxiety. But like I said, the two go really well together. In this time, in time of pandemics, in times of problems, depression soon will follow anxiety. Sometimes the anxiety will come first, but usually when you're going to see one, you're going to see the other. And we are going to see, wholeheartedly, I know this, an increase in substance abuse after this pandemic because of the worsening of anxiety that we're seeing in our patients and the increase in frequency of alcohol consumption. I mean, it's hard to go on a Zoom or even the parent-teacher meetings that we're having with the school, and the parents aren't joking about having to drink to get through teaching their kids through the day. It's a joke, but when it becomes a daily habit, it's going to become a problem. And that behavior is going to be even harder to break, because once we start opening bars and restaurants, a lot of people are going to be drinking and celebrating and going out, increasing alcohol consumption there. And when you've got daily alcohol consumption for months and months at a time, it's going to be really hard to stop once the person realizes that it might be interfering with the other areas of their life. And so that's why you kind of have to basically identify it early on. This statistic's kind of scary. 42.8% of people with lifetime generalized anxiety disorder will also experience a substance use disorder during their lifetime. You know, it's easy to cope when, you know, a cocktail can do such a good job at relaxing you. It's the habitual use that becomes a problem. And again, people with generalized anxiety disorder, 61% will go on to have a major depressive disorder. So you have to be mindful and catch it early on if you can, especially since anxiety might be the first thing that you're noticing. So enter COVID-19. You know, it's called COVID-19 because in 2019, at the end of 2019, this all started, right? But we didn't really hear about it until just a few months ago, where it really became a reality for us. You know, there's a lot of physicians on this line, but there's a lot of people who aren't physicians. So to kind of give a context, it started bubbling in conversation when you're in your clinic or your hospital about, oh, what if this happens here? What if this comes here? What if we get a lot of cases all of a sudden? People start getting anxious as it becomes more real. We're talking about February, right? People are getting upset. Well, they told us everything's going to be fine. It's just like the flu. They told us as long as we wash our hands and we're fine, this and that. So the anxiety started to bubble. And the concern, you know, was coming from the news and the media, and then we'd have grand rounds or we'd have meetings at our hospitals or our clinics. And then we start hearing that there's not enough masks, there's not enough ventilators. We started to get concerned. Providers became under pressure all of a sudden because as soon as they started to close doors, certain types of offices and clinics had to also close their doors. I talked to ophthalmologist friends, dermatologist friends. They're all saying the same thing. I'm working less. I had to furlough people. I had to lay people off. Financially, I don't know how I'm going to keep the doors open. I don't know how I'm going to keep my staff. I don't know what's going to happen to my patients. This is a huge source of anxiety. In addition to, oh, I don't want to get coronavirus. I don't want to pass it on to anybody. Interactions become more stressful. You're uncertain about what's happening. A lot of people had to shift to telemedicine. I just did that recently myself. You don't know what you're doing. You're hoping you're doing it right. No one's really guiding you. You're just kind of going. That causes a lot of anxiety because your role, your career, everything has been uprooted. So when, I'm going to make sure to, yep, okay, good. So those are for the people who aren't on the front lines. And then you've got people on the front lines who are thinking, oh my gosh, what if I get it? What if I give it to my family? What worst case scenario? What if I die from this? This anxiety becomes palpable at a certain point. You know, you're hearing your colleagues. I started really worrying. I have a cousin who's an emergency room physician, and you know, day one this happened, I'm sitting there biting my nails for her. People are absorbing other people's anxiety, and that doesn't help. It doesn't take away someone else's anxiety, but it becomes a problem because it spreads like wildfire. The focus on the lack of PPE, and just to repeat, PPE is personal protective equipment. Those are the masks, the gloves, the visors, the things that you hear about on the news. And that is to protect those who are in contact with people with coronavirus. This became a big source of news and concern. And it was interesting. And I thought, kind of as my, psychiatrist analyst on my brain here, I thought, okay, this is interesting. This is symbolic. What is this? It's a tangible focus. And in a way, it can be helpful. So what does that mean? For example, it was like a church knitting group who donated a box of masks that they sat around and sewed. This is one of them, an example. And that gave people that purpose. They shared, they felt like they're part of the community, and we graciously accepted it. It made us feel support from the community. It was really nice to feel. There's certain physician groups and things like that that have reached out to one another. I've reached out with friends and colleagues that I haven't talked to in years, and we're all kind of checking in on each other. We're asking, hey, I have an extra, box of masks. Do you need masks? Or I need masks. Can you share some? Things like that. It became a source of connection. It became a solution. It gave us something that we had control over. We don't have control over who has coronavirus, but we have control over having the things that are going to make us feel safer. And when we didn't have that, we lost that sense of control. So we were just grabbing at what we could do to regain that control. It's also in a kind of, we're talking about some symbolism with the PPE. It's kind of a cloak. It's a safety blanket. And I mean, last but not least, it's essential. We need it to stay safe when we're doing physical exams, when we're meeting with patients, when we are interacting with someone who may or may not have coronavirus on a more intimate level. So what's different? In the past, when we had the Spanish flu, for example, there was no Instagram, there was no news at your fingertips. Right now, everyone has 24/7, 100% unadulterated access to the news, to the internet. But the difference between now and, hundreds of years ago is it's multiple different varied sources, some which are completely unregulated and untrue. Conspiracy theories, false information, the panic spreads quicker that way because someone's worry, again, will be picked up by someone else. Someone will believe something that may not be true, and it just pushes that anxiety even further. So what do? Tighten exposure. You have to focus on trustworthy news sources. If you can't handle it, turn it off. Turn off that app, turn off that TV. And a lot of families just have the TV on in the background for background noise or just so they don't miss anything. But I can assure you, you're not missing anything. That noise in the background, even if you're not listening, you're hearing it. Your kids are hearing it. It's getting absorbed, and it can bring your blood pressure and that anxiety up a notch. Social media is a huge form of our lives right now. Some people are watching this on Facebook Live. This is a huge platform that does so much good. However, it can also be very detrimental. It can be addictive. It's like alcohol. In small quantities, you feel good. But if it's all the time, it's hard to stop. Your brain can't regulate and control when you're going to turn this off, when you're going to turn it on. It's working on dopamine. It's your brain basically saying, yes, I want more. Ooh, look, someone liked my picture. I feel really good. You put it down. Oh, I need to feel good again. You pick it up again. But then this time you see something you don't like that doesn't make you feel good. And all of a sudden now you're just yo-yoing your emotions while you're sitting on your couch. You don't need to put yourself through that. The problem is between social media and alcohol, it's a little bit more socially acceptable. You can turn on your Facebook or your Instagram at 6 o'clock in the morning when you pry your eyes open. Whereas you take a shot of vodka, someone might question it. But this is being done 24/7 everywhere without even thinking twice about it. So we have to be mindful of it. So dopamine, which I just referred to, it's the feel-good transmitter. It interacts with the pleasure and reward center of the brain. And again, like alcohol, it instantly will gratify you. It makes you feel really good in that moment. But the problem is the long-term use, the chronic use, that up and down, up and down. Well, the ups are going to have to get higher and the downs are going to have to get lower. And that imbalance of dopamine can lead to anxiety and depression. So how do we control the exposure? You have to really set limits. You have to say, hey, I can only be on at a certain times of the day or for a certain timer. You could set on your phone. You can have an accountability partner and ask your spouse or someone, hey, if you notice during family time that I'm picking up the phone mindlessly, just remind me or kind of come up with a signal or a sign, because sometimes we don't even realize that we're doing it. How can we be resilient? how are we expected to shrug off anxiety? Doctors are really bad at this. We are notoriously known to be bad patients. So we think, okay, no, it's fine. I'll be fine. Let me just take care of this. Let me just do one more thing. Let me just see one more patient. Let me just do one thing here. And then all of a sudden, this has now snowballed into an even larger problem. And that's what we want to avoid. We want to avoid this becoming out of control. So the physician support line is it just came into creation with coronavirus, and it is this beautiful, beautiful organization with psychiatrists across the country that I am so fortunate to be a part of. And what's happening is anyone who's on the front line or is involved in any way seeing patients during this time of COVID-19 can call this number, and I have their information in the last slide. They can call this number and ask for support, whatever the support may be, or whatever the support may be needed, and get advice or counseling or whatever it is that they need in that time from a psychiatrist. And again, it's physician to physician, just kind of with coverage and malpractice at this time. But if you are a physician in the that practices in US soil, please feel free to call this number. I wanted to give a couple examples. So there was an intensivist, and that's an ICU doctor, basically. He was having a really hard time understanding and grasping as to why every time one of his COVID patients died in the ICU, that he was having a hard time with it, whereas he wasn't having this difficulty when he'd been doing this for decades, and an ICU patient dies and he just goes on with his day. This is big. This is different. It's a different time. People are processing things in a very different way. People are feeling a lot more. He's not a robot just seeing a patient in ICU. There's a little bit more there. Another example, there was an anesthesiologist who called. She was concerned as to why she wasn't on the front lines. She had her job, which wasn't anywhere that would put her in the front lines. And she felt guilty as to why she wasn't volunteering to be on the front lines and be working in the ICU and intubating patients when she was capable of doing so. So everyone has varied degrees as to what is concerning them. In this call center, the most common calls that I've been getting have been around the themes of anxiety and guilt. Another really popular theme was physicians feeling unworthy of people's praise. And I can identify with this as well, and maybe you guys can chime in at the end too. But you know, I've had people thank me, and I'm like, oh, I'm a psychiatrist. You know, what am I doing? But if you step back and say, okay, I'm going to thank you. I'm going to accept that thanks on behalf of my profession and my colleagues, because everyone's doing their best. Everyone's just trying to continue to do what they're doing, and it's just something that's new. It's a new phenomenon that we haven't experienced. People are having a hard time processing their emotions. It's affecting their personal life. They're bringing it home, whereas before they were able to compartmentalize it. Another thing that we've noticed is that barriers that were once put up have now dissolved. When you've got a patient who is not allowed to have family at the bedside to help them or console them during their last moments, the physicians and nurses have been the ones sitting there and holding their hands and letting them just breathe while they're passing away. We weren't really doing this before because we had the chaplains and the families. Now the only people who are literally at the bedside are the physicians and the nurses, and they've put down their barriers. They're putting more of their human selves out there, and that's a huge emotional toll. Another thing that was coming up is that families are asking more questions. And you don't have escape from COVID. You are talking about it at work. It's on the news. Your kids are talking about it. Your wife or husband is talking about it. There's no escape from this illness, and that can cause a huge amount of anxiety. So with the physician guilt, what do? Like I said, the praise and the gratitude for healthcare workers is there, and some feel that they aren't deserving of this. So the advice that I'm giving here is accept it on behalf of your colleagues and those who have been working so hard for our communities. There's nothing wrong in this shift in praise. The feeling of inadequacy should be kind of just shifted to what is it that you do? What is your strength? Because as soon as this ends, it's not going to disappear. All the repercussions of what have happened up until now are really going to hit hard. Mental health, mental illness is really going to skyrocket. We've got a long road ahead. And no matter what your business is, you're going to have to rebuild. So you have to stay the strength for your community and just focus on what you do and what your strengths are. Focus on staying in your lane and being the best of what it is that you do. And that really helps with anxiety to remind you. Control is a huge factor. We see it in adults, we see it in children. The children, they're acting out, things are different. They feel things are different. They're feeling the anxiety. They're absorbing their parents' anxiety. Some are regressing back, having constipation, having problems, doing the homeschooling. They're having a hard time grasping this. So keep that in mind before you immediately go to what is wrong with this kid or your spouse. What is wrong with this person? Why are they so irritable? What's going on with them lately? Well, look around. Everybody's going through the same shared experience, but everyone's reacting to it in a different way. Especially in times of a pandemic, there's so much that we can't control. You see people who are doing things that they shouldn't be doing, and you want to rip your hair out. That's not going to help you because you can't control them, and you've just brought up your blood pressure, you've brought up your anxiety, and it's just going to get you nowhere. So what's the first thing you got to do? Facts are facts, feelings are feelings. They are not the same thing. So you have to be able to separate them. Recognize what's making you feel anxious. Stop in your tracks. If you literally have to write it down, write it down. Remind yourself what you do have control over, what you don't have control over. So this is I tidied this up. Control. What can you control? You can wash your hands. You can wear a mask. You can stay home if you're feeling sick. You follow the CDC guidelines. You can control your own actions. You can't control your child's actions. You can't control your spouse's actions. You can't control your friends. You can control you. And that's already kind of questionable, but that's the only action that you can control. You can control what you eat, what you drink, how much you move. You can control the TV, the news, the readings, the social media. You have control over that. And a daily routine. You can set that for yourself. No one else can. So if you look at that, that's a lot of things that you have control over. If you focus on those, which is a huge, overwhelming list as it is, but if you focus on those, you're golden. You've got this. But again, it's not easy. So just take it one step at a time. If that list is overwhelming, start with washing your hands. Keep it basic. Make a list for yourself. What you don't have control over, this pandemic. If I could turn it off, I'd have turned it off by now. If I could control what the president's saying and what the news is saying and what the random guy I went to high school with on Facebook is saying, I would have done it by now. We don't know when the stores are going to open. We don't know when the schools are going to open. We have no control over that. So if we continue to worry over that, we're not helping it. We're making it worse for ourselves. Treatment modalities. What can we do? There's therapy, mindfulness exercises, which is very popular and on trend here in Los Angeles, exercise, and medication. And I'm going to just review those really quickly with everyone. So there's different forms of anxiety management. So we've got relaxation training, breathing retraining, positive thinking, self-talk, replacing that negative, I'm going to lose control, I'm going to have a panic attack, oh my God, with I've done it before and I'm going to do it again. I'm going to be fine. Assertiveness training, teaching how to express your wishes and concerns and emotions and to do so without alienating others. Thought stopping, stopping those distressing and negative thoughts by coming in. So a lot of these you can't just do on your own. We don't just learn it. You could get a self-help book, but this is when you get a therapist. And this is why therapy is beautiful, because it doesn't have to be for the rest of your life. You learn some great tools and some great skills. You're golden because you can continue doing that yourself without anyone there with you. Small changes can have a huge impact. Start to organize things, make lists, talk it out, focus on what you can do, focus on your strengths, let go of what you cannot control, set up that routine. Allowed regression is something I like to do or give an example to my patients. You're having a rough day, you want to kind of crawl back in the room, turn on a favorite movie from your childhood. It's okay. Just take that moment, take what that time you need, and then pick yourself up and keep going. Lifestyle modification is very important. You need to sleep properly. You need to eat properly. You need to get that exercise. You need to get that fresh air. We all know it. I don't need to tell you, but I'm reminding you because you know exactly what you need to do. And set limits for those providers, for those physicians out there. It's okay to hear your patient's concerns, but don't make them your own. You are not going to be able to solve these problems. You're not going to be able to cure coronavirus. So just take that subconsciously away from you. Like I said in the beginning, it's okay to have some anxiety. This is biologically part of our fight or flight system. This is meant to kick us into action so that we can take the extra precautions to stay safe. If that means being more mindful of not touching your face while you're at work, or being really diligent about keeping a really safe clinic, then good, use that anxiety to your benefit. Medication is huge, right? So we've got various categories of medication here, and I'm going to just jump right in. Patients love benzodiazepines. They're always asking me for benzodiazepines, and it's not because they're all drug addicts. It's because it works. It works quick. It's a Band-Aid. It's not a solution. Lorazepam or Ativan is the most commonly prescribed medication in our healthcare settings. It's got a long half-life. We can give it to those really agitated patients in the emergency room via intramuscular form, and you can take it in pill form at home. So this one's a great one, but the most commonly asked for medication is Xanax. People want Xanax, but why? Because it works quickly. It works quickly, it wears off quickly, you don't get groggy, and they're gonna ask for that. And I wanted to point out today, because there are physicians watching, the controlled substances need to be regulated. And so California, I'm in California. And so if you're watching in another state, please check with your local state for their rules. But California has a prescription drug monitoring program called the CURES, Controlled Substance Utilization Review and Evaluation System. So this is a database for Schedule 2, 3, and 4 controlled drugs. Why am I bringing this up? So if you are prescribing this medication, so typically maybe you don't normally, but now people are more anxious, so you've been prescribing it more frequently, you need to know, specifically here in California and other states, that you need to go through the CURES program, because your mom's friend's Aunt Nora, who may need Ativan, may be getting it from five different doctors, and you need to check that. But the government is saying it's our responsibility to check that. So you have to make sure that you are doing it properly. I put the website address at the bottom of the slide if you want to take notes on that. And that's really important because, again, this is a safety measure put in place for this controlled substance. Buspirone is an anxiety medication that's not controlled. We like this one. Patients don't like it as much, but it is a good medication with relatively low side effects, med-med interactions. This medication is to be taken daily. It's not taken as a PRN or otherwise known as an as-need-be basis. You don't just take it when you're feeling anxious. You take it daily to avoid being anxious. It's called Buspar as well, not to be confused with bupropion or Wellbutrin, which is an antidepressant. This is Buspirone. And again, relatively low side effects. And then you've got SSRIs, or the typical classical antidepressants. These are taken again daily, just as you would for depression. This is going to take a little longer to kick in than depression. So depression, you see effect within 6 to 8 weeks. With anxiety, you're going to see about 8 to 10 weeks minimum. I'm thinking at least 3 months. The results are gradual, but they are effective. And these have side effects, just like any other medications have side effects. But some patients can tolerate some more than others. Wellbutrin or bupropion is a very popular antidepressant that we prescribe because it doesn't gain weight. Not everyone gains weight, but some people gain weight on antidepressants, and typically Wellbutrin does not cause that. So patients want this medication. However, I want to point out, this does not cover anxiety. This is not an SSRI, so it does not cover anxiety the way the others like Prozac, fluoxetine, or venlafaxine effexor do. Gabapentin is used off-label. And what does off-label mean? It means it's not an FDA-approved indication. So Gabapentin is FDA approved for, let's say, diabetic neuropathy, or the leg pain that diabetics have, or for seizure disorders. But people found that it relieved anxiety. So we have been using it off-label. So it's still FDA approved, but not for anxiety as the indication. We like to use this because it's easy to give to our patients who are drug abuse patients, and it is covers other things, covers pain. So people tend to like this medication. One of the constrictions is you do take it 3 times a day. It is also an as need be basis medication though. So you only do take it when you have anxiety. Hydroxyzine is indicated for anxiety. It's also called Buspirone. It's actually an antihistamine. Antihistamine kind of like hachoo, I'm sneezing, antihistamine, that kind of thing. So it does make people sleepy. That's why I like to prescribe it at bedtime, because if you're going to be sleepy anyway, you're not going to be driving, you're going to fall asleep. So it's a good choice for patients with drug abuse history or sleep problems, and it's non-addictive. This also can be taken on an as need be basis. Proper medication management is important. So we've got a lot of family therapists or family practice medicine doctors or general medical providers who have been prescribing these medications more recently for their patients who are overwhelmed with anxiety and depression. So those providers have been doing so as a favor to the patients, but you need to keep in mind that the symptoms of anxiety need to be monitored as well. So it's good to see a psychiatrist for this, or to also see a therapist concurrently. I want to note specifically with SSRIs, there is a black box warning of increased risk of suicide in young adults. So any new medication that comes on the market, even if they haven't found the increased rate of suicide, they're automatically going to get an increased rate of suicide in young adults. And this is for safety because of the risk of suicide in such a vulnerable population. So keep that in mind if you are prescribing this. And again, the cures registry is not to be ignored, even when you're prescribing for your peers and your colleagues. You have to go through that platform if you're going to prescribe anything that's Schedule 2, 3, or 4. So kind of race through it. I don't want to take up too much of your time. The resources that I want to put people in contact with is NAMI is a great neutral, throughout the US organization for mental illness. And it has hotlines, emergency hotlines. If you're feeling vulnerable, you can call them. They'll direct you to the right hotline if they can't answer your questions. The physician support line, again, is a peer-to-peer, physician-to-physician for those working on the front lines or who are affected by COVID-19. You can visit the website or the phone number here. And I wanted to bring up 311. A lot of patients don't know, or people don't know about 311. So just like you would call 911 or 411 or 211, 311 is a number that you can call and you can ask for your, let's say you don't have insurance and you need to see a therapist or a psychiatrist. You would just say what area you live in and they'll find you the closest free or low cost clinic in your area. And you're welcome to email me. This is my new website that just launched. And I think we're going to open this time up to questions. So I'll close this out.
Okay, well, thank you so much, Dr. Shirikjian. This was a very fantastic and informative lecture you gave, and a very topical discussion I hope will follow. I have to say, when you started the lecture, my anxiety was about here, and it's now melted down to kind of like right here. So that's a good start.
That's good.
I'd also ask anybody who is viewing the lecture live, please use the question and answer section to ask your questions. We already have a few coming in, and I'll address them right now. So one question comes from one of our members, Dr. Anita Avedian, who's also a mental health specialist. She notes that alcohol consumption has increased during the quarantine. Mm-hmm. We have statistics on whether it's due to anxiety or boredom, or is it too soon to know?
I don't think we have the statistics. So I think the main thing we need to focus on is not figuring out why people are doing it, but realizing and identifying that it is a habit. So even if it is out of boredom, even if it's anxiety, if that becomes a perpetual thing daily, it's going to be really easy to continue that behavior even once the boredom lifts, because like I was kind of alluding to earlier, people are then going to go out and celebrate more, and the drinking is going to continue. They're going to constantly find a reason. And so maybe now more than ever, kind of what we were taught in medical school, right? Check in to see what people are actually drinking and ask again to get kind of maybe a more clear picture of what the consumption is. Because a lot of it is justified, you know? Some people are saying, oh, as long as I don't drink before 5 o'clock, it's okay. Yeah, but then if it's daily, then you know, it's a slippery slope. So we just have to be mindful.
Thank you. And she actually has a follow-up question. Is the overall rate of anxiety increasing in the last couple of months? Has that been measured, and do we know those statistics?
It has measured. The statistics that I was seeing was varied. So it's kind of hard. And I mean, where is this data coming from? It's not an IMH, it's coming from random polls. So the number is shifted, but I know it's gone up. And it tends, the trend has been, it goes up once some sort of new large piece of information has been given out to the community. For example, the schools were all closed. Anxiety went up, right? You know, oh, wait, those stores were open, following weekend they're closed, anxiety surge, right? So you see an increase in certain types of consumption of, let's say, news, right? And it's kind of congruent with that.
Very nice. And since we're talking about controlled substances, Dr. Huri Kushakchan had a question. Would you talk about marijuana-induced anxiety?
Marijuana-induced anxiety is a whole other PowerPoint, so I'll be back in the future for that one. So marijuana, I'm in California, and marijuana is legal and fine and dandy. And you can ask many of my colleagues who are going to say marijuana is fine and legal and dandy. But I can assure you that the amount of anxiety, the amount of depression, more so depression and insomnia that I see because of marijuana, it just doesn't make sense. So it's not that it's addictive, it is a habitual process. So just like you would do anything days on end, to stop it abruptly is going to be really hard. And then you become dependent on it. People are becoming dependent on it to sleep or to, you know, do whatever it is that they do. They cannot relax without it because they've become so accustomed to it. And that's when it becomes a problem, when that routine or that behavior is interrupted. And then that's when we see a big problem with anxiety and depression.
And I will also add to that, just from a pulmonary health perspective, people who are smoking anything, including marijuana, which is thought to be less dangerous than tobacco, are more vulnerable to the coronavirus if it does affect them.
Right.
We have another question by Dr. Aboyan. What do you think about valerian medication?
Like valerian root and things like that? Yes. Okay. So anything, so just like we did, anything that's FDA approved, we've got data, we've got scientific, we've got clinical, we've got evidence. I can tell you based on that, but we don't really have studies on that. That has not been tested properly the way that we need to see that scientific data. So I have patients who do use it and that can help. But I cannot speak to its true efficacy because there is no true full, you know, published data on it. I do have some patients that say it helps. I've never had a patient who said like, oh, it's changed my life completely. If they have, they came back months later with the same problem, even though they were still taking it. So, you know, it's not going to hurt, but I don't have data to tell you how well it helps.
Okay, and sort of on those lines, Dr. Kalfayan was asking, can you comment on the role of bioidentical hormones in anxiety disorders in postmenopausal women?
Well, I'm gonna have to pull up some articles on that. But anything when you're talking about hormones, right? Anything when you're talking, anything in disrupting your endocrine system, you're gonna have some issues with anxiety. So cortisol is our body's natural, you know, chemical to help balance stress. When those levels are thrown off, we're not going to handle stress well. We're going to be either too stressed or completely just like on the floor and can't handle anything. So it's hard to say about explicitly how it may affect anxiety. And I'm sure there's some published data, which I'm happy to look into and get back to you on, but I don't have that on that specific, very specific endocrine disorder. But it does definitely affect, and we do see patients complain of anxiety when they're getting any sort of hormonal treatment.
Well, since you're talking about stress, oh, sorry, Dr. Sepilian, go ahead.
Yeah, as a reproductive endocrinologist, I could comment on some of the official positions from our professional societies as it pertains to biological or bioidentical hormones, is that, our college, the American College of Obstetrics and Gynecology, recommends that to be very cautious when consuming bioidentical hormones, as because first of all, they're not under any oversight, and as such, as they can have varying degrees of potencies, it should really be consumed under caution, so to speak. And Dr. Shirikjian, I have to say that, some of the points you hit were spot on. I'm looking at the screen and I'm seeing Dr. Barkhudarian Garni, who's a dear friend and a colleague, and over the past month, couple of months, he's a neurosurgeon, for those of you who don't know him, and specializes in doing brain surgery going through the nose. It's kind of like fixing the car engine going through the muffler, so to speak, and it's some of the most high risk areas. And a couple of weeks ago, he was about to start surgery. We were talking about. We had a meeting in organizing some of these educational webinars, and we were brainstorming, and he had to say that, hey, sorry guys, I have to go and put on my multiple layers of personal protective equipment to go do a procedure of a patient who was suspected of having COVID-19, who had had a spontaneous CSF or cerebral sinus fluid leak. And
they have a good memory, Viken.
And so as you were talking about, some physicians who are truly on the front lines and truly taking care of patients, but also from the standpoint of a physician who is not on the front line. I'm a fertility specialist. However, on a daily basis, I'm bombarded by colleagues and friends and the network of, family or friends who are concerned, who may be well, but are concerned, but, the phone doesn't stop ringing, or text messages and emails. Indeed, it has created a scenario of guilt. I almost feel like, and I did call some of the hospitals where I am on staff and put my name as a volunteer in case they become shorthanded. But there is a question from Salpia Karagian on post-traumatic stress in healthcare professionals. What are your comments on that? What is the expectation from the mental health community insofar as risk for healthcare professionals in developing post-traumatic stress disorders post-COVID-19?
Mm-hmm. It is definitely a concern. So it's certain situations. I mean, overall, the coronavirus, if you're not on the front lines or something happened, who knows what specific level of trauma, but some physicians are seeing some things that are causing a lot of discomfort and upset to the patient, to the providers. This can become a source of PTSD. So I think early intervention and identification is key, because you have a really delicate time frame of really assessing it and helping patients process or physicians process it. Because if it goes unnoticed, it can creep up on them. They can start having nightmares or flashbacks. If for example, if there's some sort of injury to the physician, if something happens to someone and they can't recover from it, and it changes the entire trajectory of their lives, that could be a huge source of, or a huge reason that they might have PTSD. And then you're looking at constantly thinking back and having, flashbacks to this time, or having, meeting the criteria basically for PTSD. And one of the components of PTSD is anxiety. So just because we're having anxiety right now doesn't mean that we're going to have PTSD and it's going to bubble into that. It's just, it is possible. But the trauma has to be severe enough. It can't just be this general shared experience that we're all having. But a lot of physicians, from what I'm hearing on the support line, are going through some pretty intense stuff. So those would warrant a traumatic event, because it doesn't have to necessarily happen to you. It can be witnessed. So we just have to be mindful of checking in on our peers and making sure that they do get the help that they need.
I absolutely agree. And there have been a couple of comments on the chat coming in with regards to just the mental health of our caregivers. Obviously, we've heard of what's been going on in New York, which is, of course, much more severe than what we're seeing here on the West Coast. And even up to physician suicides, things like that have been really traumatic for everybody to hear. And I 100% agree that we need to be working together in solidarity to make sure that we're all taken care of. And it's not just the physicians, it's everybody taking care of these patients, our critical care nurses, our ER physicians, ER nurses, anybody at the front lines really are susceptible. I was just in the ICU today and I bumped into one of the intensivists, and she looked beat. And they're just working so hard, and they want a vacation, they want a break from this. And even then, where do you go? You just go back to the same thing. So it's tough. We got to be there together. But along those lines, I do want to ask about, you mentioned briefly about mindfulness. And when I've had mindfulness training, one of the points was that there's good stress and bad stress. And if you can harness good stress for getting you through the day or getting you through whatever tasks you have to get over, how does that compare to bad stress? And I wonder if you can talk about that for a little bit.
Sure. So trying to think of a good example, but basically you have to, mindfulness I may not be eloquently describing it, but it's basically kind of being in the moment, being aware of what you're experiencing, being aware of what you're feeling, being mindful of what's going on around you, but more importantly, how you are in that environment. So when we have anxiety that gets us to get up and start our work day, like, oh, I got a lot to do today. I got to go. Oh, I'm getting kind of anxious. Oh, I have a 10 o'clock, I have an 11 o'clock. Okay, I'm going to go. Sometimes that anxiety can be good. Like that gets you up, that gets you going, that makes you productive. But if it becomes a point where you're saying, I can't get out of bed, I can't handle that 10 o'clock, I can't handle that 11 o'clock, instead of being productive with this anxiety, I'm going to turn around and do something that's harmful to myself. Not necessarily directly, but I'm just going to sit here and eat a bag of Oreos for breakfast because I don't know how to handle this emotion. So I'm just going to do what I instantly want to do in this moment. So you have to kind of stop and, for lack of a better term, be mindful of what it is that you are experiencing, and take that and be able to harness it and say, like I was talking about the positive, negative, instead of saying, I can't get through this, saying, I got through this yesterday, I'm going to do it again today. So what do I have to get done? Let me make a list. Let me use this anxiety to propel me forward, instead of giving me 2 steps back.
Well, thank you. I think that's well said. It looks like Dr. Sepilian froze. I do have a sort of a follow-up from one of our members. Do you feel that psychedelic medicine in either microdoses or dosage that can cause dissociation have a role in anxiety treatment or other mood disorders?
It can. And so I do clinical research, and we did do clinical research in this. So I didn't disclose that in the beginning because I didn't think I'd be talking about this today. So to disclose, I do research for different pharmaceutical companies that have tested these medications. So for example, there's esketamine is really hot on the market right now. There's people who are doing ketamine clinics. I don't do that, but I am more comfortable with esketamine since it's studied and it's FDA approved. So on knowing the data that the FDA has put out, I can confidently tell you that it does have its place. What it is more for is depression. It's not clinically indicated yet for anxiety. It doesn't really harness the anxiety because it actually causes a little bit more anxiety with, like you just alluded to, the dissociation. So dissociation, for those who don't know, it's kind of having like a trip. Your, colors become more vivid, sounds louder, you're kind of experiencing things around you in a very different way. And so that is dissociation, and that is a side effect. It's not the treatment goal. It's not an end goal. It's not what we're trying to get. It is technically a side effect to those psychedelics, or like esketamine, for example. So what people experience can actually cause anxiety, but it's transient. It'll go away. Like for the esketamine in the studies, they found the peak was at 40 minutes. At the 2-hour mark, the transient dissociation and anxiety went away. So that's not really going to have a big effect in the long run. It's just like a side effect with dosing. I'm not going to tell you, oh, the antidepressants will cause nausea the rest of your life. It's usually just in the beginning with dosing and whatnot. So it's just, but it's definitely not an indication yet as far as the FDA approves.
All right, I have one comment to make, and then I had another question that may be more practical in nature. One of the comments, you had mentioned that physicians and nurses were feeling a lot more stress at the bedside because families are not there in critical times. And, when their loved ones are very sick or passing. And so I think the hospital systems have recognized this, and at least in our system, at the Providence Health Systems, we are now allowing visitors to come in for anybody who is in critically ill end of life situation, and for that very reason, as well as the bonding with the loved one. And also with some humanitarian exemptions, we are bringing other people in, like say you have a child that is sick and whatnot. So we are starting to open that up with appropriate protection in place.
I'm happy to hear that.
Hopefully that will go across the rest of the hospitals out there.
Yeah, I'm happy to hear that.
And the question I had for you, so obviously you're endeavoring into the telemedicine portal that, and we've had some great lectures by none other than Rami Apelian, one of our board members, about telemedicine and how it's working well. We've been also doing telemedicine for our long-term patients, and I wanted to get your sense on how you felt that was going from a stress perspective, from an anxiety perspective. And I'll just say from my experience, when a patient is sitting on their couch and they're hanging out with their spouse and they're maybe sipping their drink, they look a lot more relaxed, even when I'm talking about really serious things, than if they were in my office in the sterile environment and, all of the other things that go along with that. I wondered if you had any experience with that.
Yeah, it is different. So I have a therapy patient that I see, and in my office, it's just me and her. But for some reason, she thinks that her phone is exempt from this. So she'll be sitting there texting and like giggling to something that someone's texting. And so I'm like, oh, okay. She would never do that in a real life session, right? But it's happening. So it is different. Some people are taking a little bit more casually. In this moment, it's the best we have, right? We have to work with the tools that we have been given. Some patients don't need to come into the clinic, so they don't come into the clinic. Some patients aren't acute and they'll be okay, and they're going to be okay, right? But I mean, they may be taking a more casual approach, but maybe what they're hearing is still going in one ear and out the other, even if they're sitting in our offices, who knows? But again, it's better than nothing. The thing is, though, I think it's going to continue. I think a lot of people, especially my industry, I don't have to touch my patients for the most part. Yes, when I do physical exams, or if they've got certain things like medications that need labs or EKGs, we'll bring them in. But a lot of psychiatrists are shifting to telemedicine on a more permanent basis. So we kind of have to get with the times. And especially if you've got immunocompromised patients that you're going to try to see more remotely in the future, that's a great benefit. That's going to help a lot of the system on your end and on their end. So we have to kind of adapt and find our way. And maybe that means they'll find their way too. it's all new. There's no real handbook on this. So we're writing it as we go.
I couldn't agree more. I think there are a lot of bad things that have happened due to coronavirus, but that may be one of a few good things that came out of this.
Right.
We're really able to reach our patients in a different way that may be more acceptable in their lifestyle, as well as some of the challenges they may have with mobility and
Right. Right. More fragile patients can stay home. Mm-hmm.
Dr. Sipilian, did you want to add anything to this discussion?
Yeah, there is a comment
time.
from Dr. Pilavian, Charles Pilavian. Physicians and nurses are witnessing mortalities on a large scale. The level of stress is unprecedented, is his comment. I just want to also add to that Dr. Pilavian, who has a doctorate in psychology, he also will be addressing our audience on pandemics in general and evidence. What is the evidence in how people cope during times of pandemics from a historical perspective? Thank you, Dr. Pilavian, for that comment. And indeed, we, like I said, we encourage all of you to, if appropriate, to go to our website and take the post-exercise quiz to claim your continuing education credits. And Dr. Shirikjian, I just really want to thank you for this very, very informative lecture. It really, I can say from personally, it hit on some it hit on some points, and not just me personally, also talking with colleagues who are on the front lines in different parts of the world. By the way, we have been doing weekly meetings as a network of organizations throughout the world where there were, there's physicians in 20 different cities where or groups of physicians, and we've been getting together Sunday mornings and sort of sharing experiences and whatever have you, including some people from New York, from Paris, from Moscow, from Armenia, from the Middle East, London, different specialists, and getting the different perspectives on what's happening in everybody's backyard. There's a strong common thread, but there's also unique nuances that are occurring in everybody's various countries and cities, actually. And some of the points that you hit on are very much so what I've been hearing from colleagues from all over the world. So thank you very much, Lara, for this very informative lecture. We would love to have you back to enlighten us again on these important subjects dealing with mental health, as well as physician and healthcare professional well-being. And Garni, thank you very much as well for doing everything that you do. You're still in your office in your surgical scrubs. I see the N95 mask behind you over your shoulder. I know you're out there on the front lines operating in an area that is very high risk to begin with. You truly are a hero. And thank you very much, everybody, for participating in this event. We'll be back tomorrow night. Tomorrow night, we have a very interesting topic on obesity and COVID-19. We have a world-renowned obesity specialist, Professor Carolina Bovian from New York, who will be joining us. The session tomorrow will be at 6 p.m. Pacific time, 6 p.m. So it's 1 hour earlier than usual. So please join us, and we hope to see you then. Thank you again, everyone. Please be well. Please heed some of the advice that we heard today from Dr. Shirikjian. Stay well, stay strong, take care of yourselves and your well-being so we can best take care of others. Thank you. Have a great evening. We'll see you tomorrow.
Thank you. Thank you all.
Thank you.